Hello, my name is Kayla Smith. Today we're going to be showcasing our research project. Our title is Integration of Tech-Supported Communication Techniques for Post-Stroke Patients. This was originally meant to be a quality improvement project. Our aim was to limit the rates of depression in post-stroke patients who are suffering from aphasia. We pooled evidence from numerous sources and found that patients with aphasia have almost a 20% higher rate of depression than folks who do not suffer from aphasia after a stroke. So we wanted to figure out how we could make a change in that number, in those rates of depression. We found that current interventions often include a nurse creatively kind of intervening with maybe a pen or paper. And then they also have laminated communication boards with individual letters and phrases. They kind of look like a Ouija board with the letters. So we were looking at more efficient ways of allowing the patient to have more autonomy through communication and found AAC devices. So an AAC device, or an augmentative and alternative communication device, is a tool that helps someone communicate. In general, AAC can refer to many strategies and tools designed to assist or replace verbal speech. But specifically, an AAC device refers to technology such as a tablet or computer that assists with communication. We chose to use Lingraphica as our generic kind of app, AAC. They offer mini tablets that are customizable for each patient. And they also offer training programs that we would use to host education sessions for our employees. We're planning to gauge the results of this intervention by administering pre- and post-research depression surveys. However, due to the change in climate, we found evidence to support the idea that implementing AAC tablet devices reduces the rates of depression in patients with aphasia in the first month of recovery. So this team suggests policy action and education workshops to enhance the implementation of this evidence-based practice on the stroke unit. Thank you.
Hi, my name is Emily Samra, and I will be discussing the evidence portion of our poster with you. As Kayla mentioned, we looked at a specific app called Lingraphica. Lingraphica offers 3 different types of apps that can equate to the patient-specific needs to communicate. It offers a 57% satisfaction rate amongst its users for its ability to help communication, which really sparked our interest in the app. Using that information, we decided to see its effect on helping aphasia patients who are also suffering from depression. And we originally compared regular cognitive behavioral therapy on non-aphasia patients as well as aphasia patients who are both suffering from depression. And we found that those who didn't have aphasia had an 84% satisfaction rate with cognitive behavioral therapy, but only a 55% satisfaction rate for those who were suffering from aphasia. So this kind of indicated that regular communication and just communication boards specifically don't work as well for aphasia patients. So we knew we had to find another source that could help aphasia patients suffering from depression. So digging deeper, we found studies that use intensive language therapy, such as the app like Lingraphica, to help those suffering from aphasia with depression. So based on the Beck's Depression Inventory, which is a psychometric test that is used to measure the severity of depression, there was a 40% drop in the score, indicating that using Lingraphica to communicate will help indeed lower depression rates.
Hello everyone. Current evidence-based policy regarding the diagnosis of aphasia patients in the hospital begin with imaging techniques such as CT or an MRI. This allows for diagnosis of the specific type of aphasia a patient may be expressing, such as Wernicke's area, which leads to forming speech, but they can't process speech. Broca's area may be affected, which leads to trouble speaking and writing, but they can understand what is being said to them. Global aphasia means they can't understand speech and they can't also express speech. This leaves them with a very limited amount of communication at all. Once they are diagnosed, speech and language pathologists will normally come to the bedside and perform a series of very simple tests to evaluate what kind of therapy they might need and what focus area they should be looking at. for that patient. These tests include repeating simple phrases, pointing to and identifying objects on a chart, or memory techniques such as repeating words and then having them being repeated back. They will also test swallowing at the bedside to make sure that the aphasia is not affecting their ability to eat. Hearing may also be tested, though this is not usually done at the bedside, but hearing can play a significant role with these patients because if you can't hear, that may hinder your processing as well, unrelated to the aphasia post-stroke. After diagnosis, they will usually stay in the hospital to continue their care. Communication boards are the leading choice to assist these patients with communication at the bedside. Pen and paper is sometimes offered for those who can write but may not be able to formulate the words correctly. This is not as common. The communication boards include pictures of activities. They include the alphabet, so you can, a little bit like a Ouija board, you can point and spell out what is trying to be said. And that is the leading choice. They are available at nurses' stations, so as it is determined for that patient, they can be given the board. It is left in their room on the bedside. Anyone can use it. There's not a lot of training that needs to be done for this type of communication. Some nurses, it's not evidence-based practice, but from working in the hospital and being on the unit, some nurses will use their cell phones as a way to communicate with the patients. They will open up a text message or a note and type in, what they want to say, and then give the phone to that patient and allow the patient to type in text, because we are in an information age and a technological age where that is a much more common practice. So it is not evidence-based practice, but it is being done at the bedside frequently. However, nurses are not utilizing the communication boards effectively according to the evidence-based practice. While we were on the unit for that short period of time before clinicals were canceled, we noticed that the communication boards would be in the rooms with the patients, but the nurses were not using them to communicate. They were struggling more trying to speak to them, trying to understand what the patient was being said. They were not picking up the board and offering it to the patient or using it themselves to communicate with the patient. For whatever reason, I'm not sure, because it is a very easy thing to use, but it is not being used effectively. This can also be related to the lack of teamwork and cohesiveness, because once speech and language pathologies perform their therapy for that patient, they then leave to go to their other patients and continue their job. But nurses and nurse managers and CNAs and other staff are not being instructed as to how to continue that therapy with that patient throughout the day. So they are only getting their limited amount during their acute stay at the hospital, and then everyone else is sort of left to struggle with that communication for that patient. And in the long term, I think that limits their ability to regain function while they're staying there. Nurses are sometimes using the cell phones and the texting, as was already mentioned, to assist with communication, but with older patients that may not be the most beneficial because they have no training. So what we are trying to show is that using an app or using higher technologies and then training everybody on these practices would be more beneficial for everybody, and also allow for that patient to continue what they are learning with their speech and language pathologist and extend it to everybody for their level of care. This increases patient outcomes. This will increase stress levels for those who are trying to communicate with that patient and give them the best kind of care. It would also minimize stress for families, because then they also have a reliable way to communicate with that patient as well as everybody else. Thank you.
Implications for nursing practice. Nurses will obtain training through the hospital on high-intensity speech-language therapy and begin this therapy in the acute post-stroke phase for patients with aphasia. This includes the nurses learning on different types of application softwares and which ones work best with which patients. Nurses will then provide patient education on the plan of care and how to properly use the applications to be most effective. A focused assessment is important at this time, and we suggest that the response to therapy is important to document. To do this, you can take the patient satisfaction surveys and the stroke and aphasia quality of life scale. Progression data needs to be recorded at this time, as well as a mental health assessment. We suggest using the Stroke Aphasic Depression Questionnaire. It's important that the nurse collaborates with other members of the care team to provide the best centered patient care.
For the topic for making the policy evidence-based practice, these actions or interventions would include, first, determining the post-stroke patient's diagnosed with aphasia. Then we would identify the current communication techniques. So that means if they're already using a communication board or anything, and then we would categorize that. We would then assess and record the patient's aphasia severity along with their current view on their own quality of life, their well-being, their mood, patient satisfaction, and mental health status. We would do that by using standardized questionnaires. These questionnaires include the Boston Diagnostic Aphasia Exam, the Stroke Aphasic Depression Questionnaire, the Assessment for Living with Aphasia, General Health Questionnaire, and Communicative Access Measures for Stroke. Then we would obtain and provide tablets for the unit. This would be done by borrowing them from other units or departments and within the hospital. Then we would provide training workshops for the staff, so that includes any nurses, nursing assistants, healthcare providers, and any other team members related to this part of the patient's care. We would provide an individualized care plan for the application for each patient, and this would be done using the patient's chart information and discussing it with their healthcare provider to provide the best communication care plan for that patient. The patient education regarding the aspects of utilizing this application, that'll be done through the nurses that went through the workshop training. And then before discharge, a reassessment of language ability and all these standardized questionnaires will be given again to observe and analyze the changes. So for the overall discussion, we can talk about the limitations involved, and those include a small sample size because although it is a neurology unit, the amount of post-stroke patients with aphasia varies, and we can't predict the amount of patients there will be at the time. Limitations also include a short duration and financial barriers, and that's related to obtaining the necessary amount of tablets. The limitations are within respect to our clinical scheduling and the resources provided. So in conclusion, the evidence collected from our systematic review show that the best evidence-based practice for reducing depression and providing optimal outcomes for successful communication in these patients includes utilizing computer-based technology of the application software. We hypothesize that this would show similar results favoring the computer-based technology over the communication boards on the unit.